everyone. I'm Ed Stever, President of the National Foundation of Swallowing Disorders. I'm also a head and neck cancer survivor diagnosed with severe dysphagia in 2007. And you're joining us for our first T.A.D talk, talking about dysphagia. As many of you already know, the mission of the foundation is to improve the quality of life for all of those with dysphagia. We do that by providing patient support, offering educational programs such as this T.A.D talk, raising awareness and promoting promising research. There's a few housekeeping items. You will be muted during the presentation unless unmuted by an organizer to ask a question. And there's two ways to ask a question. You can type your question into the question box, or you can ask the question live by typing ask live question into the question box, and a very brief synopsis of what your question will be. I'd like to introduce Dr. Michelle Ciucci. I've been working with Michelle for almost a decade. She's a professor at the University of Wisconsin, and she's been on the foundation board for the past 9 years. And I have two very brief stories about how Michelle and I have worked together to help the community that's outside of her professorship role. She and I worked together on a petition in 2013 to help raise dysphagia awareness in Congress and NIH. We collected 2,500 mini stories on the impact dysphagia has on people's lives. We used this to arrange meetings with representatives from both the House and the Senate. And in addition, we were also invited by NIH to present our findings. And we had a very productive awareness-raising meeting for several hours with 4 NIH departments. And the second story, Michelle made her dysphagia class know that there was a summer internship opening in 2014. And one of a dozen applicants who applied from across the country was in her course. That intern was Elizabeth Lipton Daly, who is now the executive director of the foundation. Elizabeth also developed the idea for these T.A.D talks that we're hosting. So I guess the adage of what goes around comes around seems appropriate in this situation. And with that, I would like to turn this over to Michelle.
Thank you so much. Hopefully everybody can see me and hear me. I'll just get some verification.
Yep, everything
Okay.
looks so.
Perfect. Thank you so much for that wonderful introduction. It has been an honor working with the foundation for these past 9 years, and I think we do some really great work. So also thank you for continuing to support us here. So in thinking about this, I thought maybe instead of talking about research, we would just go a bigger picture and talk about what dysphagia is and what kinds of problems you might see in neurologic disease, and why we don't have really great solutions yet. So the irony isn't lost on me. Why isn't there a pill for that yet? Because we all know that swallowing pills is one of the hardest swallowing functions that we have. So I'm really happy to take questions, especially at the end. Please feel free to either write them, or if you would like to indicate, we can unmute you as well. And right off the bat, we just wanted to do a couple of polls. And so the first one we wanted to ask is, where is everybody hailing from tonight? So Elizabeth is going to put up this poll. There's only 5 questions. We realize there's more than 5 areas of the world, but just to get a quick survey of where people are coming from. And then I'm not sure if I can see that. Oh, there we go.
So then when I close it here, Michelle, it should pop up on everybody's screen. I'll give people just a few more seconds. All right, I'll share the results here. Hopefully you can see that. So it looks like 81% are participating from North America, and the next runner-up is from Australia.
Yeah, about 15 hours off too. So I guess the next day there. So hi everybody from all around the world. It's really nice that we can all attend. And then of course this is also recorded, and I've posted the slides, so they're a handout, and that's for you to have in case you forget something. Okay, are we ready to jump in here?
Yes, I think so. Did you want to ask the second poll question, or
yes,
is that for later?
Yes, I did now. I did want to ask the second poll question. Okay, so we have one more poll, and then I was just wondering who the audience is tonight.
All right, I'll give people just a few more seconds here.
And we recognize there might be more than one answer, so as in all hard college tests, just choose the best one for you at the moment.
Here's the results for that one. It looks like almost 70% are speech language pathologists, and then a handful of learning disorders, family members, healthcare providers, and students.
Great. So this is about what we expected for this. And I'm gearing this again toward a wider audience, because I think one of the most important things that we can do as speech pathologists and other kinds of medical professionals is to learn how to talk about dysphagia with everybody, not just our own colleagues. Okay, so I'm going to jump right into this. And you can see my slides again?
Yep, looks good.
Okay, great. Okay, so deglutition is the entire act of eating. So when we talk about swallowing, we usually think about the physical act of swallowing through the mouth and down through the throat into the esophagus. But when we talk about dysphagia, we want to think about deglutition. And this is a complex set of behaviors. So right off the bat, we need to think about our autonomic drive to eat or drink, so that we are regulated by our thirst and hunger cycles. And there's definitely a limbic and emotional component. So we all know that we don't just eat or drink just to sustain ourselves. I probably would eat a little bit more healthy if that was the case. But there's a big reward component to this as well. We need to have appropriate sensory processing of the food or the liquid, otherwise known as the bolus, that we're going to ingest. And so it's really important how the food looks, that we can recognize it, and then also how it smells and of course tastes. And this also plays into the rewarding components. Then we have to have intact cognition. So we need to be able to recognize what it is we're eating and drinking. We need to be able to pay attention and regulate our behaviors. And then what we focus on the most is the motor component. And so that is the actual act of getting the food or liquid into your mouth. So remember that, you know, sometimes when people have other kinds of dysphagia issues, it can come along with affecting the limbs or the ability to move, for example, or get even, you know, start the process of eating or drinking. So we have to always keep that in mind. And then, of course, our chewing, our food preparation, and our swallowing. And swallowing actually doesn't end when the bolus gets into your esophagus. Of course, it goes through the GI tract as well. And we have a lot of, you know, post-swallowing processing that goes on in our nervous system as well. And the foods that we eat can affect things like our wakefulness and our mood, and of course, our nutrition and our hydration. So when we talk about swallowing clinically, oftentimes we do talk about, you know, sort of the chewing and moving the bolus from the mouth into the esophagus as speech language pathologists. Remember that this is controlled by the nervous system. So this controls the movement patterns for swallowing. This isn't just a simple reflex. These are actually highly integrated, highly coordinated, complex acts. And we use our central and peripheral nervous systems also for motivation, food recognition, in addition to getting the bolus into our mouths and the actual act of swallowing. We need intact oral anatomy for bolus preparation and containment. We need our pharynx, which is our throat, our larynx, which is our voice box, our velum, which is our soft palate, and our tongue to transit the bolus to the esophagus. And then we need to protect the airway. So while we are swallowing, we need to seal off some cavities. So seal off the cavity to the nose, seal off the cavity to the larynx, and then we need to open up our upper esophageal sphincter so that we have a safe and efficient transport of the bolus from our mouth into the esophagus. And this all happens really, really quickly. And then we need our lower airway. Sometimes the bolus doesn't go down the right way, and that happens even in young, healthy people. But we need our lower airway to cough, and then also to coordinate breathing and help us to protect our lungs. So a lot of pieces and parts of the body are involved here in swallowing as well. Okay, another poll for you. Some of you will know this because we talk about it in the course, but just take your best guess in this next poll. How many times a day do we swallow?
Can you see the results, Michelle, on your screen?
Yep. We have about 68% voted. So 94 of you are correct. So I'll switch back over now if you close the poll. We swallow about 600 times a day, and only about 200 to 250 of those are with food. So as we're talking about, you know, about what can we do to help treat dysphagia, for example, a lot of times we're focused on what people are eating and drinking, but we need to remember that most of the swallows that we do are with saliva. And so oftentimes we forget about the impact of managing saliva, of managing oral care. And even if somebody is not eating something by mouth, it doesn't mean that they are not at risk for getting aspiration pneumonia, because they are going to potentially aspirate on their oral secretions, for example. And then at night when we're sleeping, this slows down a little bit. We swallow about 50 times when we're asleep, and then factor in about the 8 or so spiders. Just kidding. I know some of you are laughing. It's also really important to remember that swallowing requires oral contents, lubrication. So you need to actually have a bolus, something to swallow. Oftentimes it's saliva. And then, as we know, dysphagia or disordered swallowing has serious consequences to health, quality of life, to healthcare costs, and participation in life events. So swallowing is complex. Like we mentioned, it involves precise coordination of 50 muscles. pairs of muscles and 6 cranial nerves. So it's not just a simple reflex as people are sometimes taught, and it requires a lot of sensory and motor integration. So Corinne Jones put this together. Oh, I didn't want that up there, sorry. Okay, that was me narrating this. So what you're seeing here actually is a moving x-ray of somebody swallowing. And we have an instrument, sorry about that. We have an instrument called a high resolution manometer, and it's a catheter that has pressure sensors all along it. And we can look at pressure and timing events during swallowing. And so I'm playing this video to show you that this is a highly complex integrated act that involves all of those muscles and nerves that I showed you. So this is an x-ray and it's from a side view. And then these colored dots here are representing pressure along the nasopharynx, the pharynx, and then into the esophagus. And when they are colored blue, it means that there's relatively low pressure. And when they're the cooler colors like red, they're high pressures. And so here at the upper esophageal sphincter at rest, there's a lot of high pressure because it's closed. And then everything else is sort of at rest. So as I'm going through this, what you'll see is that as this substance is swallowed down and it's just some liquid mixed in with barium, you'll see how there'll be high pressure following it down, helping to squeeze it down, and also high pressure in the areas sealing off the larynx and the nasopharynx, and then lower pressure as the bolus enters the cavity. Oh, I guess it does not want to. I'm going to do this because we can at least just follow it down. Pardon me for 1 second. Can you still see my screen, Elizabeth?
Yep, I can see your screen. Oh. It's just presentation mode.
Yep, it's just going to be like this for now. So I'm going to flip through these frames, and then you can see this bolus, the barium going down. And so what you're going to see here is cooler colors following it. I'm sorry, warmer colors following it and cooler colors ahead of it. So you can see that we're closing off the airway, we're closing off the nasopharynx, and we have to open up the upper esophageal sphincter. And this happens so quickly in 700 milliseconds. And so I just hope you get an appreciation for how highly complex and coordinated this is, and then how hard it is then to study the physiology, because this happens, deep within our throats here. So I love this slide. This is courtesy of one of our colleagues here at the University of Wisconsin, the amazing Dr. Nicole Robles-Leah. And so in order to have good swallowing, we need appropriate strength, oral sensation, motor planning, and then lubrication. And if we have issues with these, and then we add on something like cognitive dysfunction, then we end up getting a swallowing impairment. And any and all of these can be impaired in many conditions that cause dysphagia. So dysphagia is not a disease in itself. Dysphagia is a condition that happens because of many different kinds of etiologies. And so a big one that we talked about and that Ed talked about that he has lived with for a long time, dysphagia associated with head and neck cancer, but we also have other kinds of neurologic disease. So progressive neurologic disease such as ALS and Parkinson disease, dementia or Alzheimer's disease. You can have trauma or a stroke as well. And all of these can lead to a dysphagia and can impair the many aspects that we need to be intact to have safe and efficient swallowing. And then just to remember, dining is a social activity that revolves around communication. So dining with friends, family, and work colleagues can be negatively impacted with dysphagia. Oftentimes people have a reluctance to eat in public due to embarrassment about drooling or slowness of eating, fear of choking. And then importantly, patients may also have difficulty with reach to eat movements, which can negatively impact feeding as well. It's really important to dispel the rumor or the myth that dysphagia only happens in later stages in progressive neurologic disease. Swallowing changes occur early in Parkinson disease, Alzheimer's disease, and ALS. Now, swallowing changes may not lead to a severe dysfunction at first, but changes can often predict that swallowing is going to be impacted. And so this is something that's really important to, as clinicians, that we tell other clinicians, that we make our patients aware of, and that we make sure that we're providing enough education and feedback to people so that the practitioners know to look out for early changes of swallowing. We don't want to react to a dysphagia. We don't want to wait until somebody is losing weight and becoming dehydrated and getting aspiration pneumonia. We want to know that dysphagia is a reality that can occur very early in many of these conditions. And so if you leave with anything tonight, that's one of the things that I would really like everybody to remember and to advocate for. And then another great slide by Nicole again. Also, patients will underreport dysphagia. And part of the reason is because sometimes they're not asked those questions. So even with Parkinson disease, for example, people might have a dysarthria, which is difficulty talking. They might have dysphagia and other kinds of problems, but the kinds of questions that they get asked will focus more on tremor and walking and sleeping. And so oftentimes this doesn't get asked and it doesn't get noticed. And I'll give you some tips and tricks about how to ask specific questions about this. Okay, so as I mentioned in the early stages, sometimes swallowing will look functional, but it's not necessarily normal. And so Corinne Jones and I did a study with this high resolution manometry catheter. And we looked at patients early on in diagnosis of Parkinson's disease. And with this technique that combined using this moving X-ray and this high resolution pressure sensor equipment, we found that their swallowing was different. It was pretty functional, but it was still different. But then across time, as you get to later stages, then dysphagia really worsens. And so what you'll see in this video is an inefficient swallow, because you can see this bolus is left behind, and then an unsafe swallow because it's getting into the larynx and down into the trachea and into the lungs, and this person's having difficulty coughing and clearing it out. And so I guess the second point is what happens during disease progression to cause this kind of widespread dysfunction? And unfortunately, we really don't know the answer to that. And the reason is because I explained before that swallowing is highly complex. It involves a lot of different kinds of muscles and nerves and areas of the peripheral and central nervous system, and also several systems, motor systems, sensory systems, cognition, autonomic nervous system function. And so because of this kind of complexity, neurologic disease can have a significant impact on that as well. So I'm going to take one neurologic disease, Parkinson's disease, and we'll talk a little bit about how we know that this affects more than we originally thought as a framework to talk about other kinds of diseases. So when you learn about Parkinson's disease, you learn that nigrostriatal dopamine depletion leads to this movement disorder, bradykinesia, postural instability, tremor, and rigidity. And these are the hallmark signs of Parkinson's disease. This is when somebody would probably go to the neurologist. But people also have difficulty walking, hypokinesia, and then even early on, cognitive deficits, depression, sensory impairment, autonomic dysfunction, and then importantly to us, dysphagia and dysarthria. And so it turns out actually in this really nice series of studies, what happens across time in Parkinson's disease is that the dopamine neurons that cause the classical signs don't degenerate until about mid-stage of the disease. And there's degeneration that happens in lower areas of the brain, and some of those areas are responsible for regulating swallowing and digestion and autonomic function. And so one of the first things that really helped us to understand Parkinson's disease and dysphagia a lot better was that a lot more of the brain was involved than originally thought. That's why probably the pills that people took to help their tremor weren't helping their swallowing. And then as the disease progresses, even more areas of the brain are affected. And as we talked about before, since swallowing is controlled by almost every single part of the brain, it's no wonder that as this disease progresses, the dysphagia can worsen. But the important point is that it's actually there early on. And now we think of Parkinson's disease as a whole body disease. And we know that early on in the disease process, there are some signs and symptoms that were typically attributed to aging before. But this is a really, really nice review in Nature Reviews Neuroscience. And there's also been some studies done that if you look, this is a sample of a larynx. If you look in the muscles and the nerves in the larynx and the pharynx that control swallowing, in patients with Parkinson's disease that had a worse dysphagia, there was evidence of hallmark pathology in the form of some misfolded proteins that are classic with Parkinson's disease. So instead of just Parkinson's disease being an issue with dopamine and an issue in certain areas of the brain, we know now that Parkinson's disease likely affects the entire body. Now, how that happens and when that happens is still a mystery. But this framework of, Parkinson's disease really happening about 10 years prior to a diagnosis is starting to be recognized in other kinds of diseases, such as Alzheimer's disease and even ALS. And the reason why this is important is because there's features across these neurologic diseases that are similar. And so in this next slide that I'll show you, which is a little bit busy, what it's showing is your central nervous system and then your enteric nervous system or your gut. And there's interactions between your gut and your brain. And so in any of these diseases, one thing is common among all of them, and that is there's some kind of inflammation. Now, how that inflammation gets turned on, how it exacerbates, how it manifests, and then how it actually ends up harming the nervous system is different for different diseases, but it's really a common theme. So you get inflammation, and then you get some kind of misfolding of proteins, or you get reduced clearance of substances, like maybe if you're talking about Alzheimer's disease, like amyloid beta, for example, some of you might know about. And this causes dysfunction and cellular death. What we don't know necessarily is, what turns on these cascades and what causes people to be more susceptible. We know that there are some genetic influences and some environmental influences. But the point is, all of these diseases affect almost the entire body, certainly the peripheral and the central nervous system, which again is involved in swallowing. And so you can have an appreciation of how hard it is to parse apart what's going on and how does dysphagia start, and then how does it progress and manifest, and what can we do about it. So currently, right now, we don't have neurosurgical interventions or pills that help with swallowing deficits because we don't really understand the manifestation over time, but we are working on that. And dysphagia is really hard to study in neurologic disease. First of all, because there's a prodrome or a preclinical stage where people are not necessarily showing firm signs of the disease, or they're being missed or ignored. As I mentioned, we don't know the mechanisms. And then when you're trying to do controlled studies in humans, we have a lot of variability with age, sex, the phenotype of the disease. So not all dementias are the same. Not all Parkinson's disease is the same. The onset, the progression, people have medical comorbidities. They're on different kinds of medications. They have different diets, lifestyles, beliefs, and support systems. And so in trying to get a cohort of patients to study that are similar, enough that you could find differences, in maybe if we find a treatment that we think might help, so they need to be similar enough so that they'll maybe respond in the same way. It's hard to do because they're so variable. So it gets a little bit messy. And I'm not talking about this tonight, but this is where a lot of the work in animal models comes in. But I would say for everybody, so we don't have a pill and we don't have neurosurgery, but we do have approaches. And really awareness is the key to approaching dysphagia in any kind of neurologic disease. And so we don't want people to say to us, oh, well, that dysphagia only happens in the later stages. Don't worry about that now. So we need to get educated. We need to learn about the pathology that's specific to the type of disease that we might have, and understand, for example, the way we think about Parkinson's disease now in 2022 is completely different than when I first started learning about it in 2002. Also, we think of Parkinson's disease as a movement disorder, and we think of dementia as a cognitive disorder, and we think of ALS as a neuromuscular disorder. But many of these diseases have non-classical signs and symptoms, and a lot of these have to do with ingestive type behaviors like chewing, swallowing, breathing regulation, digestion, elimination, and also sensory issues and other kinds of systems that we talked about that go into the whole deglutition experience. And so we need to be able to recognize what those are as well, and not sort of brush them off as, well, that doesn't really fit the model. And we need to know that dysphagia is present upon diagnosis, and it will progress. It might be a little different for everybody, but we don't want to think that it's something that's going to necessarily happen later. So we want to stay right on top of it. It's also really important that you get to an appropriate medical specialist. I put in dysarthria here too, because these really go hand in hand, very, same muscles and nerves. And as speech pathologists, we treat both of those. But we want to make sure that our speech pathologists and our neurologists and our care team, and especially the patient who's at the very center of our care team, has education about the disease itself and swallowing and dysphagia and also communication problems. And I task all of us with doing more outreach. So making sure that we're training our students appropriately, that we're reaching other professionals, and that we really take the time to explain what's happening with our patients. Okay, so how do you know if you're a patient, if I have or my person has a swallowing disorder? So let's say newly diagnosed, or maybe just having some issues and are thinking about going to the neurologist. Here's some good questions to ask. Are there any kind of foods that you don't eat anymore? Is there anything that's difficult to eat or drink? Do you cough during or after eating? Does your voice get gurgly or wet while you eat and drink? Have you had pneumonia recently? Does something feel stuck in your throat? Have you lost weight? Or do things maybe sometimes come back up? And so if you answer yes to these questions, I think this is a good opportunity to think about getting evaluated. One thing that I always talk about is it's a more rare complication, but you have an increased risk of choking with dysphagia. And as we know, choking is a life-threatening event that happens, and all caregivers should learn basic life-saving skills. I can't tell you how many times people have said, I'm so glad you told me to do that because my baby choked or my uncle choked. So everybody do this. Sign up Red Cross today. So I think evaluation early is really important. Now, when we talk about this, especially with clinicians, sometimes you have to justify why you're doing things. And so if somebody's not having an overt dysphagia, with pneumonias, they'll say, well, it might not get paid for. And so that's something that we can talk about either offline or at the end of the session as well. But just like anything, we make the case of getting baseline evaluation. So my 12 and 14-year-old daughters just got their blood drawn for cholesterol evaluation, not because they're showing any kinds of signs that they might have high cholesterol, but we know that cholesterol is genetic, that high cholesterol does run in my family, and so getting a baseline study for their cholesterol is really important to see if it changes. Now, it's a little bit apples to oranges, but when somebody is diagnosed with a neurologic disease, I think it's very appropriate to do a thorough diagnostic workup and know, what you're starting with, especially because there are data, there are papers that show that there is early dysphagia, and you have some of those citations in your slides there. And we want to use the appropriate tools. So we want to do instrumented evaluations. So early, often, especially if there's progression or things change, using the kinds of tools that will give you a difference. So in that Example I gave you about Parkinson disease, when we evaluated with a modified barium swallow study, we didn't find any differences between early Parkinson disease and age-matched healthy controls. We did find differences though in a high resolution manometry. Now I know not everybody has that, but one of the strongest indicators was a patient-reported outcome called the Sydney Swallowing Questionnaire. And so there's a couple of questions on there where people marked that they had difficulty with eating and drinking certain things. And I'll show you an example of that in a moment. So even these, because patients don't report, and it often goes under notice, even a pretty cheap and simple patient-reported outcome and asking the right question can be your best tool. So always get caregiver inputs. Do a CSE as a clinical swallowing evaluation. And instrumentation is really the key because we do want to have a hypothesis-driven evaluation and then a treatment plan based on data. So here's a Sydney Swallow questionnaire. So here's some example of the questions. And then this is a visual analog scale. So how much difficulty do you have swallowing hard foods such as steak, raw fruit, and raw vegetables? And then a person may put a line somewhere. And so the Sydney Swallowing Questionnaire is actually really good at picking up early dysphagia in Parkinson disease. And this has been replicated in other kinds of studies as well. Okay, these are red for the clinicians. So general principles of treatment, this is that they are hypothesis driven and impairment based. So we need to base our treatment on our evaluation and our evaluation is going to look at the physiology. How does the etiology that this person has cause dysphagia? What are the key features of the dysphagia for this person? What systems are affected? So not just what happened to the bolus, for example, but was it safe and efficient? Are there sensory, strength, cognitive kinds of issues, impaired ability to cough, for example, as well? And then what specific impairment should you address and in what order? So these are sort of the big picture items that clinicians should always be thinking about. And then in terms of management, so I didn't want to focus so much on management today because it really depends on what's going on and there's not a one size fits all. But oftentimes our management approaches have to do with restorative and rehabilitative functions. So improving strength of the tongue, for example, or improving the ability to cough. We oftentimes use compensatory maneuvers, so having somebody hold their breath or tuck their chin or swallow a couple of times each bolus. And sometimes we do recommend alternative nutrition and hydration, either to supplement or if safety is significantly compromised. And all of these tools can be used in combination, and they should be laid out in a treatment plan that was done by somebody who has the expertise to do this. And so it's not something that you can just Google, WebMD and say, okay, I have Parkinson disease, here's the 3 things I should be doing. So this really needs to be based upon the evaluation. So no, we don't have a pill, but we do have a lot of approaches that we can use as part of the team to address dysphagia. And I think that's the good news about this talk tonight. So I'll say that I've said this again, and I will keep saying it, proper medical management by the speech language pathologist and the physician team is vital to management. People need to get a swallowing evaluation, a clinical swallowing evaluation, which consists of asking questions, taking a history, doing a neurologic cranial nerve exam, having people swallow, eat or drink in front of you. We have instrumented evaluations that we can use. And then you really need a team. So you need a qualified speech pathologist, a neurologist who knows the disorder. So not all neurologists are the same. So for example, if you have Parkinson disease, I recommend that you go to a movement disorder specialist. If you have Alzheimer's, going to somebody who specializes in dementia versus something, a neuromuscular specialist for ALS. And then a really great person to have on that team who knows a lot about swallowing physiology is also our friendly otolaryngology teams, head and neck, or ENT they're called. And the most important person on this management team is the patient. So we need to ask about training institutions, clinical positions, and experience when we're looking for expertise. And we also need to consider individualized needs. So we need to know what's going on for the person. What are their swallowing situations where they need the most help? What are their preferences? What kind of access do they have? What kind of resources like time and finances? You know, when people have a stroke, for example, they might be doing rehabilitation in a lot of different ways. And so you can't expect somebody to do, you know, 4 hours of PT and 4 hours of OT and 4 hours of swallowing and cognitive work a day while they're driving back and forth to appointments, etc. And sometimes people don't have access to transportation. So oftentimes we need to think about, you know, what is the most important thing to do for this individual patient. And then wellness. And I think, you know, the more we consider a holistic approach, we consider wellness. And so this is where places like the foundation come in. Support groups are really important. We need comfortable environments where people share similar problems. It helps to reduce embarrassment and shame, and it helps to increase confidence. And caregiver support is also vital because this typically happens, you know, within a familial group. Okay, so in summary, why don't we have a pill yet? Well, swallowing is a complex set of behaviors involving the whole brain and body. And neurologic disease also involves complex behaviors in the whole brain and body. And truthfully, neurologic disease is not well understood. But what can we do? We can understand how swallowing works. We can understand our disease and how it affects us. We can be part of a qualified team. We can participate in our own healthcare, and we can build resiliency. So with that, that's a picture of the fog steam coming off of the Lake Mendota here in Madison, and I wanted to say thank you. I know some of our students are on. Thank you so much to the foundation for having me, and thank you to everybody who logged on tonight and sat through yet another Zoom meeting. And I'm super happy to take questions.
Thank you, Michelle. That was wonderful. We have a few questions here. And just as a reminder, if you have questions, please feel free to type them into the question box. And if you would like to ask them out loud, you're welcome to type in live question or just let us know that you would like to ask it live, and I'll try to unmute your mic on your end if you have a question, but I'll just get started here. We have a caregiver that has joined us tonight who says that their partner had a swallowing evaluation and was recommended to be on a modified diet of pureed foods and thickened liquids. And this person said they would sooner die than eat that modified diet. And the caregiver is really concerned about balancing safety, but also recognizing that quality of life and enjoying eating and drinking is so important. How would you approach that situation, both with the caregiver and also with the person with dysphagia?
That is such a great question, and it's one that I think we all struggle with in terms of making recommendations and then having to live with the recommendations that are made to us. And so, and I think it depends on the situation and what the goals of your person are as well. And then, you know, it depends, I guess, too. It can get a little complicated because it's different if somebody might be, let's say, at the end of their life. And they know that they only have so much time and they just like to enjoy, you know, the final weeks or months that they might have, versus somebody where they might not be facing, you know, mortality quite as quickly. For me, again, without knowing the specifics, I think it warrants a longer, better conversation, meaning, and maybe a more in-depth evaluation, because you know, if somebody is aspirating on thin liquids, for example, we know that thickened liquids can be helpful, but they can also cause more dehydration, and people don't like to comply anyway. And so is there a safer way, for example, to drink liquids? So, you know, are there any compensatory maneuvers or something like the free water program where a person might you know, brush their teeth, rinse their mouth out, and then just eat ice chips and drink filtered water, and then just, you know, cough and clear after, so that they can just go ahead and drink water without worrying about aspiration pneumonia as much. So that is something to definitely ask about. And then, are there foods that are safer? Or are there, is there fatigue involved where maybe the first couple bites need to, are something that's a little bit harder to eat, maybe less safe, and then to get the actual calories in, maybe there's some adjustments. And then there are like a lot of good cookbooks and tips and tricks as well. But it comes at a cost of time too, because I'm sure, nobody has like 7 hours a day to be modifying and prepping food. So I guess I would say, like, what are the risks of eating a diet that's more in line with a person who wants to eat? Are they getting aspiration pneumonia and significant hospitalizations? Is it going to shorten their life and they don't want that to happen? So I guess just kind of considering a holistic approach and having more conversations about it is the way to go, if that helps. Again, without really knowing the specifics.
Thanks, Michelle. That's some good insight on a potentially tough conversation to have with everybody involved. Here's another question that we got, and we get this through the foundation quite often. People wondering whether exercise and treatment is contraindicated in people with neurodegenerative diseases like ALS, and what your take is on that.
Yeah, I love talking about this. This is one of those myths that has kind of survived across time. So there are sometimes some contraindications. So this is me not giving like blanket medical advice, but more of a, with things like, especially with degenerative disease like ALS, that tends to go a little bit more quickly and can cause fatigue. People worry about getting tired and then getting into like a respiratory issue where breathing might be, difficult by fatiguing somebody by exercising. But the thing is, when you contract your muscles, all sorts of things happen. They remain strong. They give off neurotrophic factors, which are really important for maintaining, the health of the muscle and the nerve to muscle connection and the brain. And so you can imagine if we didn't eat or drink anything all day long, all day, every day, we would fatigue and our swallowing would get worse too. So I think there's a huge role of exercise in maintaining function or maybe regaining function, just as long as you're going about it, again, in a hypothesis-driven way. Like, there's certain exercises that you should do based on trying to compensate for whatever the impaired physiology is, but also not being, not like falling to the myth of, you just should stop exercising and only conserve energy. But again, it's a conversation after the medical professional, because there might be some other things going on, for example, that I don't know about this general advice, but I think when people have neurodegenerative disease, a couple of things happen. You lose function, which is hard. It makes things just harder to do. You have to ask for help a lot. It's, oftentimes it comes at the cost of not being able to communicate as well. So you start to get isolated. And then when things are hard and you get isolated and you're always asking for help, then you don't want to do things as much. So then that, you get more isolated, and then when you get more isolated, it's just kind of this vicious cycle. So as much as you can get out there and participate and be eating and drinking and talking to people and making sure that, your dining is a pleasant experience, because that's a big part of why we eat and drink in addition to surviving. I think that's a really important thing to do. So don't let anybody tell you you shouldn't exercise. Ask why. And what's that based on? Where's the data? What does the current literature say?
Absolutely, yeah, you have to be your own best advocate in these situations a lot of times. I have another question for you, Michelle. You had mentioned, similar to that blood work story that you shared about your daughters, is that people should have a baseline evaluation. Is that something that insurance will cover if you're not demonstrating any clinical symptoms? And how often should that be repeated?
Yeah, so that is, again, a great question too. So I think when you get a diagnosis of something like dementia or ALS or Parkinson disease, you probably are having clinical symptoms, but people aren't asking the right kinds of questions. There is, in early Parkinson disease, for example, some people have a pretty significant swallowing impairment that they just don't know about, and they actually are silently aspirating and right away, and some people aren't. So because a lot of aspiration is silent, because a lot of dysphagia is subtle, not having clinical symptoms based on one question that somebody might have asked them. So I think it's worth it, again, to ask for a speech pathology evaluation, go to somebody who knows about Parkinson's disease and who knows how to ask the right kinds of questions to tease apart, like, is this person having a dysphagia, and what can we do about it early on to preserve function? So, and it should be covered by insurance, because dysphagia happens early on in these disease processes. But I do live in reality, and I understand that theoretically that should happen. Doesn't always happen in practice. So sometimes, again, you need to have some conversations, especially like with the referring physician or with a speech pathologist or with the insurance company, where you say, okay, well, do you just want, I guess we'll just wait until I'm hospitalized for aspiration pneumonia. Do you want to do that dance, this kind of thing? So you can get it covered. It's just sometimes a little bit of a back and forth. But I think there's probably something there. Maybe you don't need a modified barium swallow study right away, but it would be really important to ask those questions and to, watch what that person's eating, monitor weight. All of a sudden, when you start paying attention, then you do notice, like, oh, I am coughing each time I eat. I wonder what's going on here.
Thanks. We have a follow-up to that. You had mentioned that it's so important to have a specialist who understands what they're looking for. How does somebody find the right swallowing specialist or neurologist that can help with their disease?
Yep. So oftentimes, so I know, like, the foundation here, oftentimes people will reach out and say, I have this, this thing going on in the city. Do you know of people? Oftentimes when there's good academic medical centers nearby, might be a ways away from you, but oftentimes they'll know who to refer you to if you're a little bit like outside of that geographic area. Oftentimes, like, the disease specific websites, like the Wisconsin chapter of the American Parkinson's Disease Association knows who the clinicians are, across the state of Wisconsin, for example. So you can just reach out and ask. In terms of physicians, there's a lot of board certification that happens, especially in neurology. So if you can, and you have somebody like that in your area, then you'd want to go to somebody who's board certified, for example, in movement disorders, if it's possible. It's not always possible.
Thanks, Michelle. That's something that we were talking about in our virtual support group this week, is that a lot of times people don't live nearby, like we do here in Madison, to some specialists that they can see. And so even if you're able to get to a specialist for an assessment, they can help develop a treatment program that somebody more local in your area could then implement.
Yeah.
I have another question here for you from a person with dysphagia who's been managing this since 2016. He's noticed that swallowing can be more problematic at various times, even with the same foods, and is just wondering, why is there such variability, even when eating the same foods at different times, I think, throughout the day? And Jeff, please correct me if I'm asking that incorrectly. Yeah, so just wondering, Michelle, about...
Yeah. So, and again, sometimes this can be etiology specific, but if you think about it, all the things that can affect your physiology, so your sleep, your level of hydration, if you are stressed out, if you have low blood sugar, if you're taking medications, if you're fatigued for some other reason, if you have a virus, just depending on what you just did previously. So we're actually really variable creatures. It's just, we tend to be pretty resilient, so that we don't notice all the time, when we're performing more or less poorly, unless, you really pay attention to it. So there might be a pattern, it might be multiple factors. Always, if there's something that's really important, like drinking water is really hard, then you want to optimize your time. You don't want to do it when you're distracted and stressed out and already ate a big meal. If so just trying to be like a good pattern recognizer, but it is really normal to be variable. That's why sometimes, people get a swallowing study and they'll do poorly on it, so somebody will say, oh, we have to modify your diet. But it's like, it's just a snapshot. It's just a window. And so maybe that's the best they did and we caught them at their best, or maybe that's the worst that they swallow. So it's just like one example. It's one data point. And so just sort of following that along is important too, if that makes sense.
Yeah, thanks, Michelle. We have one more question here, and then I might start to wrap things up as we come back to the top of the hour here. And I want to read this word for word just because it shows that there's so many different ways to think about the same thing. So we have a question here. It says that you mentioned modified diets often lead to dehydration. If the patient is consuming thickened liquids, wouldn't that promote hydration? Aren't patients more likely to drink if they aren't as concerned about coughing or aspirating?
Yeah, yes. So that's also an important point. So when you modify diet, so let's say modifying diets have different kinds of consequences. So if you're modifying the diets to, let's say you're pureeing food, oftentimes you're adding liquid to that so that you can get it to like a applesauce type consistency, right? So let's say, you're going to add liquid to that. So you're actually adding hydration, but then you're reducing the nutrient density because you're adding liquid to it. So you kind of make the food a little bit bigger and less dense in terms of nutrients. When you add a thickener, you actually reduce the ability of that liquid to hydrate by about 20 to 25%. So if you want them to drink 4 ounces of juice, but you have to thicken it, then you want them to drink 5 ounces of juice to get the same amount of hydration. But oftentimes people don't adjust enough to make up for the thickened liquids that they're drinking, and then it often takes them longer. And so and then the way that your body absorbs fluid can be different with different conditions too. But yes, if somebody is having so much trouble on thin liquids and they're doing okay with thickened liquids, then and if they're more likely to drink those thickened liquids safely and they want to, then absolutely yes. So it's one of those individualized things. So thank you for pointing it out in that direction as well. Some people just won't do it.
Thank you, Michelle, for answering all of these questions. There were a few that we didn't get to. If we did not get to your question, please feel free to email us at info@nfosd, and we can forward these on to Michelle to help answer. And with that, I'm going to invite Ed to come back on. And again, Michelle, thank you for doing this. As Ed mentioned in the beginning of this presentation, I really have you to thank for this position, working for the NFOSD, and it has been a great experience doing that. So thank you again, and I'll turn this over.
We're the lucky ones.
Michelle, thank you so much for presenting this evening. And some of the takeaways were how complex swallowing is. And if any one of those 50 contributing, I'm not sure what to call them, if they're not working, the swallow isn't working. And that's so easy to overlook. Another point that you made was that the patient is really an important part of the team, and that also is sometimes overlooked. So I think you made some amazing points, and I just want to thank you for once again jumping in and contributing and hopefully making life better for all of those with dysphagia. To the audience, there will be an email that is sent out tomorrow. It'll have a link to a 1-minute survey. We're looking for your feedback on not only today's event, but also on ideas for future topics that you would find valuable in covering. And with that, I also want to thank Elizabeth for moderating the questions and really putting this entire series together. So with that, I'm going to sign off, and Michelle, thank you again.
Thanks, everybody. Bye.
Bye-bye.